to say that the raffle has finished now, and you'll be able to pick up your prizes, all the ones you've won. And the numbers will be on the board just by the raffle table now. Also, the authors of Hope for the Best and Hope for the Best and Plan for the Rest will be leaving after lunch. So if you'd like to buy a book and have it signed and have a look, please do it at lunchtime, because they won't be available after that. And I hope people will come back. Everybody's having too much fun and too many lovely muffins out there. That's lovely, thank you. So you may remember yesterday, Philippa Sharp did an amazing presentation about neck collars and head supports, but what we couldn't do yesterday is play two very short clips, which I think are quite astonishing, and I think we just wanted to share those with you now, just before the next presentation. So I wonder if you'd be happy to play Philippa's videos. They're only a few seconds long.
And the thing is, it's so discreet, nobody would know, would they? It's not obvious.
And there's one more. So I think you'd agree that they were worth seeing, and plus I get all the credit for standing here. So thanks, Philippa, for that. I'd like to introduce the next speaker, who will be here in person with Angela Harris, who's going to be online. So this is Sarah Maguire talking about learning through grief together.
Thank you so much. I'm Sarah Maguire. I'm the Director of Community Services at ALS Canada. It's an honor and a privilege to be here today. This is such a fantastic community. Where else could you get a pep talk, a breathing exercise, and a grounding exercise before doing some public speaking? So thank you, I needed that. Angela is online. I think during the presentation, I understand that you won't necessarily see her face. Can we? Oh, we can see you. There's your lovely face. I thought you were just going to be like the divine voice or conversing with the mothership, whichever suits your belief system. So Angela, over to you for your welcome.
Hello, everyone. And I'm so sorry that I can't be there today. But I am in spirit, and I know you have the lovely Sarah there with you today. So hopefully between us, we can show in real time how working in different time zones is really a minor inconvenience. And when you have the will and the want to work together, it comes together. So my name is Angela, and I lead on the support development at MND Scotland. And if we could have the next slide, Sarah. Thank you. I wanted to give you some context for today's presentation. So last year I spoke to you in Switzerland about the findings from our What Matters to Me survey in Scotland that ran at the end of 2022. Now, the findings provided us with so much richness of information that we've been putting to use within our support offering, actually. And from the 368 responses that we had over 140 bereaved carers respond. And they were really very clear what they wanted and needed. And it was more timely support at one of the most difficult times of their lives, when they'd lost their loved ones. Support at and around the time of bereavement was much wanted and needed. We put in place a number of support mechanisms, including a support page on our website. One-to-one counselling was already available, but we also developed a number of communications to our families in a consistent and hopefully helpful way. Not too much, but timely ones that really reminded them of the help that was still available to them. And last year, we also talked about the potential to run a pilot program that would support people in a peer setting. Now, this is where my conversations with Sarah began, when we started to explore how we could support each other to share the learning on the brilliant work that ALS Canada had already done in the grief space. Sarah was really receptive, and we decided that we would pilot their grief workshop that they had invested lots of time in developing. However, we needed their help to do this, and it was agreed that they would host our pilot program, and the Scottish team would attend, co-host, record and shadow the sessions, having the opportunity to learn by experience. The team not only shadowed the sessions, but also the intake calls that form part of the process. And I'll let Sarah tell you more about that.
So this is what the workshop looked like. It's a closed group. That means that no one can join partway through. It can disrupt the feelings of safety and trust that are building up as people are making themselves very vulnerable and sharing very heavy things. It was a weekly group. It ran for 7 weeks at 1.5 hours per session. We had 2 co-facilitators. They shared various logistic responsibilities. They were there for mutual support, to troubleshoot issues, that kind of thing. We very intentionally set it to start on Valentine's Day, ending just before Easter. These were very important dates for this community, and we wanted to make sure that we had the opportunity to reduce that sense of isolation they would probably feel during those holidays, and also just make sure that we were there to provide a supportive environment for them. There were some homework and handouts to be completed, and it was really for people who felt stuck and needed some skills to move forward. And as you can see, the agenda basically explored different aspects of grief. Over to you, Angela.
Thank you. Our first cohort that attended were all female. So 5 of them had lost their partner, in this case their husband, and 1 had lost their mother. They varied, obviously, in their individual experiences, and their periods of bereavement ranged from 7 months post-bereavement to 4 years. Their age ranges were between 39 and 74. As I'd already mentioned, from MND Scotland, we had 2 members of staff, 1 a trained counsellor who shadowed all elements of the process, and also 1 staff member who supports and delivers our wellbeing services. And the workshop was hosted by Sarah and Joanna from ALS Canada. Back to you, Sarah.
Thanks, Angela. Joanna, give us a wave. She's in the room. She's another person you can ask about this group. Thanks, Joanna. So the intake process is a very important part of this. It is a very short meeting. It's via Zoom, and the purpose of it is to really understand the needs of the person. And actually, I'm going to go back to something that Linda Levine said yesterday, because I felt so validated. A lot of people have questioned whether the intake process is necessary. And when Linda referenced that, it's like clothes shopping. Not one suit is going to fit everyone. Well, that's the same for grief. Not every support is going to work for every single person's grief. Some people are looking for connection, community. They really feel cut off after they've lost their person. Some people need to redirect that caregiving energy that they have been really putting into their person who's no longer there. Other people feel stuck in their pain, as though they don't have hope. there's going to be no hope that they're going to get through this. And this workshop was really geared for the latter. Over to you, Angela.
Are we going to show the video there, Sarah? Or was that?
Oh, yes, thank you. See, this is why I need my buddy system. Sorry, over to the gentleman for Bill's video.
Sound on first thoughts that possibly that is not what I want or need.
It might just not fit with what you're looking for.
Well, I mightn't, I'll make this statement, I mightn't get as much out of it as I would hope to get, and what I definitely get out of the Marie Curie group. Now, does that make sense?
Thank you. And what I need to explain about that is that basically it's not an elimination process. A lot of people think an intake process is really to, you know, weed people out who don't qualify, or someone has to prove their eligibility. It doesn't work like that. It's simply a guided conversation so that people can really self-reflect and self-assess and determine themselves, once they know more about the program, whether it's actually something that will meet their needs, or whether it's something that won't work for them, or, you know, even possibly be a negative experience for them. So that was Bill really coming to that conclusion for himself. There are specific questions that we explore during that process, but really it's more of a conversation. Okay, over to you, Angela.
Thanks, Sarah. So we wanted to share with you some of the comments and some video from the group that says in their own words what it meant for them to be part of this group. Some described it as life-changing, but this particular comment stood out to us, and I'll just read it for you quickly. We just ended our 5th session, and I wanted to say thank you for all the time and energy you've put into this group. It has been very valuable to me, and I'm sure for others as well. I feel like I would get more out of additional weeks, and I am looking at the fact that we only have 2 more sessions. I wondered if we might be allowed to have a WhatsApp group with one another, since we have become close through our sharing, and we might continue to support each other through the ups and downs of this grief. I realise not everyone might want to participate, but I thought it could be another way that the group could continue our relationship, even though our official time together will end soon. Now, we hear again and again how connection is so important, and that people want to meet people who can really empathise with what they've experienced. Now, as a support organisations, we also don't want to keep people in their grief. We are often asked at MND Scotland if we have bereavement support groups, and we don't. But what we do want to provide is the opportunity to gain support and have connections in a way that works for individuals. Now, I'd like to share with you a couple of short videos, if I may, from the participants from the group. If we could play video 1, please, which is the 3 ladies talking about what it meant to them to take part.
Do I press the... There we go. Okay. I'm not very technically savvy. That's why I need those dudes at the back.
In terms of people who are going through the same process that I went through, and the ladies in the workshop, I would absolutely say the workshop is magical. It gave me the time and space to really reflect on what happened, how I dealt with things at that time, and knowing that other women had gone through exactly the same process, and they could understand every single feeling that you had. And that was so helpful.
I would 100% recommend the workshop. The hosts were just so helpful, non-judgmental. Just seemed to understand, gave you the time if you needed to, cry. There was no pressure.
I really looked forward to each session. I was set up 15 minutes beforehand, just waiting for it to start, and it was run really well and empathetically, and you could feel that the people involved were genuinely caring for how we felt and genuinely grateful for us sharing the stories as well.
Thank you. Could we then share the second video, which is one of the ladies' very heartfelt feedback that just seemed to encapsulate so many things?
For people at this stage who've lost a husband, a wife, a mother, a father, or whatever to MND, it's shit. But there is light at the end of a tunnel. It might be a long tunnel, but there are better days ahead, and you will work through what we've worked through. And I think what I would say is that whether it's workshops, whether it's people listening to you, don't think that it's going to stop tears, because it won't. But that's okay as well.
Thank you. Marina was very open in her feedback, and we have shared these films and obviously got permission from the guys to share them with you too. I'd now like to pass you back to Sarah to talk a little bit more about the outcomes of the programme.
Thanks, Angela. I have to take a moment because I was in that group with these incredibly beautiful and resilient people, and takes me back to some of those moments. Before I get into the outcomes, there were some similarities and there were some differences. I just want to take a moment to say that working on this with MND Scotland was very pivotal in my own understanding of bereavement and grief. We developed really fabulous connections with MND Scotland and the team, so I just wanted to express my deep, deep gratitude to Angela and her team for being an incredible buddy system for me. As you can see, I couldn't do this without her. Okay, so some of the things that we had in common, and we hear it time and time again, I'm sure it's not going to be a surprise to many people in the room. People need a specific support for ALS MND. Random, general bereavement support just doesn't cut it. We know that anticipatory grief is compounded when people are experiencing issues with the healthcare system or individuals in their lives that simply don't understand the disease. That we heard that time and time again in the group. We do know that the intake process is very necessary. Originally, 9 people had gone through the intake process and 6 people actually attended. 3 people self-reflected and decided it wasn't good for them. So that was very important. We do need 2 co-facilitators, both for logistics, managing, the technical side of things, and also to be a buddy system. We hear a lot of heavy stories, and you need that support in place. And we also know that bereavement support means different things to different people. When people say that they're looking for bereavement support, have a conversation, figure out what that means to them, because it might be very different from the next person who asks you for bereavement support. So these were some of the differences. I'm going to come back to the first one, but we noticed that obviously when you're working with different communities, look at the culture, look at the social expectations around grief and loss, look at all the different practices and make sure you hone your services to that specific community. And also the resources should be designed that way too. Now, we heard a lot in our group in Scotland about how they perceived their person's suffering. We heard that a lot. It was very distressing. When we had run groups in Canada, instead what we heard more frequently, how people were comforted if their person had died by medical assistance in dying, or if just knowing that it was an option. It wasn't information we were planning on collecting. It was something we observed during this process, and we thought that was pretty interesting. The last thing that I will mention is that there was a difference between the two groups as to who was showing up every time, who was completing the homework. Scotland got the gold stars. Canada was the rebel in the room, and we probably need to go on detention. So, and I think that concludes. Oh, Angela, next steps.
Last one, thank you. So we'll take the gold star on that one. Thank you very much. For MND Scotland, the grief workshop will now form a part of our regular support offering. And I would say Sarah and I were really keen to share our learnings with you today, because we truly believe that working together and sharing and developing support across countries, charities, and the world can truly benefit everyone. And we'd like to keep that moving. I'm going to embarrass you now, Sarah. I really value Sarah as a colleague in the same way that I value my peers within my own organisation. We have so much to learn from each other, and we've always really enjoyed working with each other. I'm speaking for us both there. And we want to spread that love and open that up offer to an international community. You know, finding real and lasting ways of making a difference in each other's worlds can be so motivating and so energizing. So let's try and find a way to make that happen. Thank you for your time today, and we'd both be delighted to answer any questions you may have.
Well, I'd like to thank you both so much for that presentation. I think to be able to describe one workshop as both magical, non-judgmental, shows that you really very clearly created a very safe space for those people. And I think it reflected in your videos, which is extraordinary. One thing I might have missed before, because I was sort of eating a raisin at the time and I missed it. But how did you two meet in the first place?
I love that question because it was here. We didn't necessarily meet directly, Angela and I, but we connected through colleagues because I attended San Diego and we spoke about our support group model, and we were about to start our bereavement work then. So this is the kind of powerful thing that happens at these meetings.
Brilliant, thank you. Whoa. A question. We have a question here.
Thank you so much for sharing. Can you talk briefly about what your programming was like for those 7 weeks, and if that's something you're willing to share?
Sorry, a breakdown of the 7 weeks? Okay, so I'm not remembering it necessarily in order, but the first couple of weeks are about really introducing themselves, getting to know each other, creating those connections. And then throughout the weeks, then we'll talk more about, you know, any lingering feelings, any anger, any guilt, anything that it's not necessarily connected just with the death of that person. It could also be connected with feelings around things that didn't go well. It could be to do with the actual ceremonies and celebrations that happen around death. And then there's a session in particular where people really talk about the active dying part, and that's a really tough one. And then we move on to moving forward, building hope, and creating a path through the grief.
We have time for one very quick question.
I have an online question from Sue Nelms in the UK. She says, what did you call the group? Death Cafe or Bereavement Workshop sound a bit glum?
That's also a fantastic question, because we had gone back and forth in ALS Canada. Originally, we called it a support group, but it was a very different model than our support group, so that was confusing. And then we just called it a group, which is, you know, not really helpful for people. And it was actually Scotland that called it a workshop. And I liked that because even though it may not appeal to people who are looking for something else, it really is what it sounds. There's work in that group. It's not just coming together, which is very important for other people, but there was actual homework and agendas to follow and tools to build and skills to build. So it was more relevant in this case, but not every bereavement support should be a workshop or called that.
Lovely.
Sorry, Angela, did you have anything to add? I completely stole the microphone.
No, I'm loving it. You're saying it perfectly. It's all good.
Great. Well, I think that's all we have time, but thank you so much.
Thank you so much.
So next up, I'd like to welcome Easton Stevenson. Somewhere? Fabulous. Who's going to be talking about moving forward after loss. It's Celeste Turner ALS Foundation support for those who have lost their partners in ALS.
Sorry, I just have to get myself set up here. A few of us in one of the master classes discussed our love for the Hallmark movies, Hallmark Channel, I should say, and one taught me to smile during a significant event, and that helps you relax. So I'm trying to relax as I'm smiling. Okay. Good morning. Good morning. My name is Easton Stevenson, and I'm a licensed clinical social worker and a support service coordinator at the Les Turner ALS Foundation. A little bit about the foundation. I'm guessing that many of you are probably aware of us, but for those of you who are not, we are a private, nonprofit support organization outside of Chicago, Illinois. We were founded in 1977 and are one of the longest serving independent ALS groups in the United States. We're committed to providing the most comprehensive care and support to people living with ALS and their families so that they can confidently navigate this disease and advance scientific research for the prevention, treatment, and cure of ALS. Oh, okay, old slide deck, sorry. I apologize, I've now lost my way. History, informal caregivers. Okay, we're just going to continue. The Les Turner ALS Foundation support service coordinators include social workers, licensed clinical professional counselors, and nurses. Together, they provide individuals and their families information about ALS, emotional support, recommendations about equipment, grants to assist care-related expenses, and many other items. We also have numerous online information guides and corresponding webinars about a variety of topics related to living with ALS. We provide decision tools, which are interactive digital documents that explain treatment options and offer reflective questions that can help an individual decide what is right for him or her. Now I'm going to talk a little bit about bereaved caregivers. According to research by Samar Awan and her colleagues, most often bereaved caregivers report that they use family and friends as a source of support during their time of grief. And interestingly, they experience the highest rate of helpfulness from those supports. People who only received help from professional resources, such as therapists, experience the lowest rate of helpfulness. Prolonged grief disorder, or PGD, is a mental health condition that involves intense and persistent grief after the loss of a loved one. Factors that can affect this risk of developing PGD include recent bereavements, not receiving enough supports while caring for a loved one, being a spouse or partner, low involvement or conflict within the family, and having a history of depression or anxiety. It was found that 63% of bereaved individuals following the death of a loved one due to motor neuron disease or ALS are at moderate to high risk for developing prolonged grief disorder. In comparison, the majority of those grieving the death of a loved one from another condition experience normal grief. Shocking, right? As per the findings by Samar Aoun and Christopher Popp and his colleagues, and the previous presentation spoke of this as well, general grief support groups are not tailored to the specific needs of people who've lost a loved one to ALS. Caregivers' grief is more likely to be prolonged and complicated, and therefore timely and tailored support is necessary. Due to the COVID-19 pandemic, partners had to grieve in isolation, resulting in further feelings of emotion and distance from family and friends, and increased potential to develop complicated grief. A gap in support for those who had recently lost a loved one was particularly profound in the first half of 2020. In the 43 years that the Les Turner ALS Foundation has been in existence, up to August of 2020, it had no formal bereavement services. We had been outstanding in our providing support to the individual living with ALS and his or her family, but for the most part, that support stopped when the individual died. Members of the support service team would acknowledge the death with a phone call, email to the spouse and family, and the office would send a condolence card. Depending on the relationship between the support service coordinator and the family, perhaps continued phone calls or emails would take place in the future. If requested, referrals were made to outside therapists who specialize in grief and loss, so that the person could do some individual work. In August of 2020, I started to think about the fact that people in and outside of the ALS community were limited in how they were able to grieve the loss of a loved one, given the gathering restrictions imposed by the pandemic. Spouses and partners were not allowed to go to the hospital to say goodbye to a loved one who was dying. Families were not allowed to hold services or celebrations of life. It was not advised that friends come over to support those who were grieving. When I thought about who was most affected by the death of a loved one due to ALS, I identified spouses and partners, given that they were often the primary caregiver for the person living with ALS, and they often had the closest relationship to that person. The bottom line is that we also provide support at the time of diagnosis and during the ALS journey leading up to the death, but it is equally essential to provide support to those who are left behind, to help them deal with their grief, to help them adjust to their new normal, and to help them figure out a way to live without their person. So given this, I contacted a fellow social worker who practices grief and loss, and she also runs bereavement groups. After asking her what a bereavement group could or should look like, I made some changes in order to be adaptable to the ALS community, and I developed the Moving Forward After Loss bereavement group. And again, I apologize, I'm not keeping up with the slides. This is a closed, structured 6-week virtual group on Zoom. It takes place on a weekday evening for 90 minutes, and the group space, even online, is a safe and judge-free zone. When thinking about what those who were grieving needed, I identified 3 primary areas: education about grief and loss, a community of others who were grieving, and a connection with those who had been through the ALS journey. The group curriculum supports those goals. Week 1, we do introductions and we review the mission, history, and rules of the group. Weeks 2 and 3, we examine the symptoms that group members have been experiencing due to their grief. These can equal emotional, physical, social, cognitive, cultural, spiritual, and religious. Hearing what other people are experiencing during their time of grief results in group members feeling validated in how they are feeling during this difficult time. Week 4, death stories. Many people have never told the story of their loved one's death to anyone. So to be able to share it in a small group is cathartic. It relieves them of having the story live in their brain with no outlets. And it provides an opportunity for one to feel supported and validated by others who have been through a similarly traumatic experience. Telling the story contributes to the process of moving forward through the grief. Week 5, theories of grief. After having shared individual experiences of grief, it's often helpful to get some perspective about the grieving process. So we review 3 primary theories: Elizabeth Kubler-Ross's 5 stages of grief, William Worden's 4 tasks of mourning, and the dual process model of grief. By providing these frameworks, group members have the opportunity to assess which theory they may relate to and where they may be in the grieving process. We also review some common myths about grief, which can also add to the education component. The final week, week 6, is show and tell. Group members are invited to bring an object to group, i.e. the screen, that was of significance to their spouse or partner, and explain the significance to this group. This results in group members getting to know the deceased on another level, and it provides the group members with an opportunity to remember their loved one outside of the ALS journey. I also provide 2 transition groups after the initial 6 weeks that take place every other week. This provides time for the group members to come back together, check in, receive support, and also get used to a little bit less frequent of meetings. Oftentimes, group members then transition to our monthly group, which I will speak about in a few minutes for continued support. So I've been hosting the Moving Forward After Loss spousal group quarterly for just over 4 years. During that time, I've hosted 15 sessions of the group. I canceled the summer session of 2024 because apparently the weather was too nice to talk about grief. So not enough people wanted to join. 59 spouses and partners attended a session of 6 weeks. Nobody attended more than 1 session. And groups averaged between 3 and 10 participants. While this may be small, this limited number of attendees provide a tight-knit community where amongst group members, and through which safety is felt and trust is formed. I asked each group member to complete an expectation sheet on which they first identify what they're hoping to get out of attending the group, any worries or concerns that they have, and finally, what they learned from attending the group. The major themes in this last section included developing relationships, experiencing a feeling of being understood, and having a sense of belonging in a safe and unique community. In this group, some people have found a place to talk about their loved one's ALS journey and death for the very first time. One of my group members was a woman who lives in rural Pennsylvania, and her husband had a tracheostomy and was dependent on a ventilator. She was his only caregiver, and they had 2 school-aged children. She shared with the group that she received no support services from an ALS organization due to how far out they lived, and she had very little support from her family and friends. She never spoke to anyone about her experience caring for her husband or what it had been like for her and her children since his passing. Can you imagine keeping that life experience to yourself? The Moving Forward Loss group gave this woman a place to speak about her experience, to share her feelings, to be validated, and to feel like she belonged to a community. She called the group a lifesaver. 2 groups from another session met up at our annual gala and danced the night away together. Other group members have met up with each other in person for the first time at our annual Walk for Life. The monthly group that I referenced earlier is called Living After Loss. This group includes spouses, partners, adult children, and siblings of people who have died from ALS. On average, the monthly group attendance is about 10 to 15 people. The format of the group is open discussion, and sometimes, if needed, topics are thrown out as well, but that's not often needed. And the group also meets on Zoom. In October of 2024, we developed a third bereavement group for young adults. This is for people ages 18 to 30, meets monthly for 90 minutes on Zoom, and that format is also open discussion. This is a group that provides a space for young adults to connect with peers who are experiencing grief, while at the same time navigating significant events such as a career, relationships, family, and personal lives. So often, group members share that other people in their lives just don't get it. They don't understand ALS. They don't understand what it can be like to care for and love someone who's living with ALS. They don't understand what it feels like to experience both grief and relief, given that their person has passed. But others have been on very similar journeys, do get it. And we, as ALS support providers, can get people connected to each other as a supportive resource while they are grieving. We're not able to save those who are living with ALS from dying, but to paraphrase my group member who said that the Moving Forward After Loss group was a lifesaver for her, we can be a lifesaver for those who have lost a loved one to ALS. If you do not already, please consider adding consistent and long-term bereavement support to those families you serve. Thank you. We thank everybody living with ALS and their families.
Easton, thank you very much for your presentation. Sarah and I were just saying, what a lovely thought to have a show and tell at a session which I've not heard before. And then I realized I have my mother's show and tell with me as all the time. So the one question, we will have time for question. And while you're going to find the microphone, are there any questions? I have a quick question for you.
Yeah.
So given we were talking about grief being very individual and being very personal to one person and never the same, is there a time that kind of normal grief turns into the prolonged grief? What kind of time frame were you thinking?
Oh, yeah, that's a good one. In my opinion, first of all, for my support groups, I don't put a time frame on when they should or shouldn't be attending a group based on how far out the death has been. So, for example, this woman in Pennsylvania, her husband died 10 years ago, and she just started our spousal group a couple of years ago. But in terms of prolonged grief, I think the main indication is almost as if somebody is actively grieving for an extended amount of time where it's affecting their function, it's affecting their life and their work lives and moments. And the previous presenters talked about being stuck. To really kind of assess whether a person is stuck for a time frame that just does not seem common. I don't like to use the word normal, but common. So, I think the profound symptoms of grief can certainly last over 6 months, over potentially even a year and a half, but it really would sort of be a matter of whether or not they're able to function in their lives.
Thank you for that. So are there any questions? Are there any questions online? Any questions in the room?
Hi, I'm Julia from the Alliance. I have a question about the demographics and if you have a gender breakdown. I was curious to know what that looked like. Thanks.
For the spousal group, it's been funny. The majority of those 15 sessions has been all women and one token male. I've had maybe a few groups with maybe 2 men, but definitely the predominance has been female. Age, I would probably say mid-40s up to low 70s.
Is there a plan for like outreach? I'm curious to know if you know why that's the case, or how you can reach, in this case, men that are potentially not attending as frequently as women, or how you do that.
Yeah, that's a great question. I can talk with my director about that later. I think, the marketing that we provide to our constituents is, of course, equal in terms of being available to men versus women. And I do try to touch base particularly with those people who I work with personally, and I request that my team members work with the people that they've supported to encourage men to attend this group. So, we can always increase our efforts to attract the male component into these groups. But I think, generally speaking, men may not be quite as interested in attending a group such as this, but I'm happy to reach out and to try to encourage.
Thank you. Thank you, Easton. I'm afraid we don't have any time for any more questions, but you'll be able to find Easton at lunchtime outside in the foyer. Thank you very much.
Thank you.
Now, our next session will be talking about the practical palliative care skills for ALS clinicians by Amberine Mehta and Cara Bish.
Thank you so much for having me. Dr. Bischoff is here, but she said we have such a limited time, we decided it was just going to be me for this presentation. But thank you again to the association for inviting us to talk about this topic. I think it says a lot that it's on such a national platform, an international platform like this. These are my disclosures. So my goal today is to share essential palliative care skills that will allow you to enhance your conversation, communications about complex decision-making with your patients and your families. And if you're a patient or a family, in doing so with your care team as well. Included in that is providing a palliative care definition that you can use when you're referring patients or care partners. And I'll review some examples of models to structure goals of care conversations. And then we'll identify when are the times in the disease to trigger these conversations, because they're not always clear, or we're kind of sometimes unsure about when to bring it up. I will note, I would be remiss if I didn't, that management of complex physical, emotional, spiritual distress is the other half of palliative care skills, but with the time we have today, we'd need an entire seminar on that, so we're gonna skip that for today. To start, palliative care refers to addressing total pain, which includes these multiple components. And these components, they impact each other. We've seen that time and time again. Emotional distress is, when that's high, there's a very high level of physical pain. And patients, you can ask them that. Do you feel like there's a component of your anxiety impacting your physical pain? They almost always can identify that. When there's social stressors in place, it affects and threatens their spiritual safety. So they're all intertwined. And we have seen that when we can impact one of these components, we can impact other components and address the suffering of our patients and care partners. These needs, they ebb and flow over time. There are components that may be more severe at certain times. The emotional and spiritual distress at the time of diagnosis may be extremely severe, more so than the physical pain, but then the physical pain later on becomes more pronounced as the disease progresses. And we also see that the shape and the form of the types of stressors, they change over time. But as you can see from this lovely graph, that at all times there's some form of palliative care need that's constant, and that needs to be addressed continuously. And so this model applies not just to that person diagnosed, as we've heard through many of the presentations today, that it also goes towards our patients' care partners and the families and anybody who's really involved in their community or their circle of life. So based on this, I'm going to ask you, when should people receive palliative care? And you'll all say together with me, at the time of diagnosis, right? So there's really no time that you separate out palliative care from the rest of care. But that doesn't necessarily mean that you need a referral to a palliative care specialist. Each of you, every single person, is involved in some sort of palliative care provision because you're actually caring to address their suffering, right? And so everyone is doing some form of palliative care. So this brings me to the clarification of primary palliative care from secondary and specialty palliative care. This graphic was just taken from a cardiology paper, but it applies to all the palliative care models that exist. Primary palliative care is the relief of suffering provided by any clinician not specifically trained in palliative care. Secondary palliative care is provided by clinicians specifically with a specialty in that training. I use the example when I teach the medical residents that you should be able to manage basic hypertension, right? When somebody's needing 1 or 2 medications for their hypertension, that can be done by, hopefully, a primary care doctor. But when it becomes more complicated, then you send them to a cardiologist. Very similarly, every single person that we meet and we train and we work with, and the patients and their care partners and the person cleaning the room, they're all providing some basic palliative skills. When it becomes complicated is when a consideration for a referral to palliative care can take place. So what does a palliative care specialist do? That's often very vague, and so going over some of these might help to give you some categories for what to think about. I've had patients come to clinic and have literally no idea why they're there, and everyone thought that they knew why they were coming, but they had no idea. So as we teach others about palliative care skills, just being here, as neurologists are getting more formal palliative care training, as the neuro-palliative care subspecialty grows in terms of formal training, and then given the limited palliative care specialty resources available, we know that not everyone is going to receive a palliative care referral. Additionally, as you remember from that graph we were looking at before with the waxing and waning palliative care needs, some people will need more specialty palliative care at certain times, and then they may not need them for a while. So I will see a patient early in their disease and then may not see them again for a year and hopefully 2, and then things become more complicated again, and then they get sent back to me to do a check-in. So what we do specifically when we see patients as a palliative care specialist, we're trained to sit with the discomfort that uncertainty brings. That is not something that people are comfortable with and not something that everybody wants to do. We can offer different ways to manage complicated symptoms. By definition, palliative care is a multidisciplinary approach. We have usually a social worker and a chaplain and a pharmacist. That's the core of a palliative care team. And that allows for us to address the multifaceted components of suffering that we were talking about. Sometimes we just offer the additional time that's needed for the patient and care partner to provide that support. I have many neurology colleagues who say, I'm trained in palliative care, but I just don't have time. It's not possible for me to address all these needs of their neurological disease while also tending to the psychosocial spiritual needs in a proper way in the time frame that I'm given. We can be a continuity of care across certain settings in the hospital, especially in the US system, there's a lot of rotations of learners in the academic hospital or hospitalists. So sometimes we are that continuity of care for the patient's story. And then of course, we'll help with transitions to the end of life care. Understanding this fundamental purpose of what palliative care is and what the definition is and what the specialist can do, we can now shift to some of the specific skills that we want to kind of address and that we use when we're really facing a lot of uncertainty and the distress of our patients and care partners. Usually I teach that if you are talking more than 50% of your conversation, you're not listening enough. So listening is the fundamental thing, and I think it's actually a core component of a palliative care fellowship and training that we work on, that we're trained to do. We know from the data that not to call out my colleagues who are specifically physicians, but in one study specifically, 70% of the physicians spoke over the other people in the conversation. And so we know that when patients and families feel heard, even if they make a complicated decision, they don't regret it later. There are some excellent studies about, for example, tracheostomy placements that the family didn't feel like they really had a choice. The disease was going forward and they had to do this. But later on, when they asked them if you regret the decision, even if the person died after getting that, they felt no regret because they felt like they were heard, they were listened to, they made a decision with that conversation done well. There is passive and active listening. So we'll know the difference with how exhausted you feel afterward. When I have learners on the service with us and we're only seeing maybe 5 or 6 patients a day, they finish the end of the day saying, I am so tired, I don't know how you do this every day. And that's compared to the 12 or 15 that they're usually managing. And that's because it's a skill that takes a lot of work and a lot of patience to sit and do. Passive listening, it's when we're thinking about the next question to ask or the next thing that we want to tell the patient or how we're going to reply to their statement. We're passively listening. When we're in the moment, listening to what they're saying with active curiosity and our emotions tuned in, not only are we actively listening, but we're taking that journey with them. And that leads sometimes to me not knowing what to say. I'll be so overwhelmed with emotion, or I'll just be genuinely stunned and I don't really know what to say about that. And my patients and families have taught me that that is okay. That's more than okay. And they can feel that real appreciation for your actively being present with them. So the silence that comes from not knowing what to say is something that is another fundamental skill in palliative care. This comfort with silence, that leads to really effective communication, which feels a little ironic, but it's true. So next we're going to talk about the values and what's the difference about values and preferences. So values are the aspects of life that patients find important. Preferences are the choices that pertain to a specific medical scenario. These are constructed from an individual's core values and influenced by multiple factors. When we put our patients' values and preferences together, that leads to an understanding of their goals for their medical care. So if their preferences are not aligned with their values, what do? Then you need to ask yourself if the patient has a poor understanding of the medical problem. Preferences are susceptible to undue influence. The more important question is, what does my patient value? And the complex medical problems demand a greater understanding of our patient values. But eliciting these patient values is not an easy discussion. The patient has to be willing and able to engage in that introspection. Many times, as we all know, people are engaging in their own introspection already. So it's a matter of giving them a safe place, an opportunity, a way, using these skills of just silence and being actively engaged and trust building to allow them to share those inner thoughts. Oftentimes, I will share with patients that these thoughts are not dependent on whether you have a neuromuscular disease or any other certain disease. It's just inherent to being a human being. We have these thoughts throughout. It's just a matter of now figuring out how to share those things in a safe and open way. Serial interviews and conversations using open-ended questions can really help them engage in these explorations. So questions like, as you look to the future, what are you hoping for, or what are you worried about? And then you follow those up using open-ended questions of why or tell me more to help them explore that further. In more difficult cases, when capacity or introspection are limited, answers can be inferred from a patient's behavior over a course of their life. And this is where we go back to understanding their values, because if they're their core values, they've been consistent. And many times when we can't talk to the patient, we often ask the family, is this different or is this new from who they are? Who they are fundamentally is the most important part that we're trying to get at. I have learned that the genuine curiosity in understanding how a disease threatens somebody's quality of life and core self is truly what allows individuals to feel safe enough to explore their values and preferences. So it's just going in with a true, genuine desire to understand what this person is living with. Their preferences can change over time, and maybe not even can change, but should change, because they're influenced by experience. The graph we were talking about earlier with the waxing and waning palliative needs, that reflects their preferences, because their preferences reflects their needs. I've had patients say at the time of diagnosis that they're completely unwilling to live with the feeding tube, and then when the time comes to actually make that decision, of course, they have a pretty good quality of life, they've experienced more of the disease, they end up agreeing to having one placed, and that's expected and appropriate. It's not a failure, it's not a lack of conversation, it's what should be happening for them. Of course, these conversations, they come with the delivery of bad news, and bad news is bad news. That's just the way it goes. I remind myself that no one personally, not myself, not the patient, no one is creating this bad news. We're all like deliverers of this message. So I will often use the phrase, your disease is making the decision for you or for all of us. That helps me with some of the guilt and fear related to giving the bad news. And data have shown that patients and care partners can be confused when we sugarcoat or are vague in our delivery. We do not have to be mean, cold, or curt when I speak to patients about this, but if you are just communicating all data and no breaks for emotion, that makes a bad combination. I have literally seen patients crying while the clinician is talking and talking. I had a team once literally back out of the room while the patient was crying. Palliative care will come in and take care of this for you. So it's better to give one or two pieces of information, even if it's incomplete, attend to the emotional, spiritual needs, and make a follow-up appointment if time runs out. This is where those skills really come into play. I'm almost out of time, aren't I? Okay. I'll just share that these are a set of specific skills that I think can be really taken away. One of the things that I think would be to highlight is asking permission from patients before you just continue on with information. I even use it to give permission, to ask permission for when I'm giving a recommendation. It really allows for a lot more partnership. And the last couple of slides I'll share with you is that these are examples of programs that are out there that have organized ways of providing serious illness conversation protocols. And one that we use at our institution is, as you can see, really heavy on talking about the patient's story, where they really, we have the patient and the family talking about who they are for the majority of the time. And in fact, sometimes that's the entire conversation. Then we'll come back to the medical pieces later on. So palliative care skills everyone's doing them. They're for everyone. Values are supposed to be constant, and preferences do vary. When we're talking about the primary skill of listening, of conversation, it's listening. And we want to think about developing our different models that can be used when we're guiding the conversation, because one size doesn't fit all. I'll just put up a few thank yous, and thank you all again for the opportunity.
Thank you so much for your really interesting presentation. I always thought that we did neuropalliative care, and now I've discovered it's got a name. We do primary palliative care.
We're doing primary neuropalliative care.
I'm very happy about that. It's a good concept. I'm just going to check if there's a question in the online. Shall we ask that first?
Thank you. I'm going to start with a comment from Rebecca Coulter with the ALS Association, who says, it's been encouraging to hear more and more about the importance of integrating palliative care over the last couple of years, given the value add. Unfortunately, in my experience, it's not widely available to people living with ALS. Would love to see these programs grow and expand to increase accessibility. And as a person living with the disease, I can't agree more with that. I've found it super helpful in my case. The question comes from Lynn Braumeier, who's a person with lived experience, who asks whether U.S. Medicare covers palliative care.
Yes. So in the U.S., a referral to a palliative care doctor or specialist or team is really just like a referral to any other specialist. So the payment and reimbursement should be exactly the same as if you were getting referred to a neurologist.
And will that carry into hospice?
Then once you translate into hospice, Medicare covers all of the hospice care. So then palliative care becomes hospice care. And while if you think of it as the big circle of palliative care and then a small circle of hospice within palliative care. So the programs will call themselves palliative care and hospice care, but when you transition into hospice, that the kind of focus of hospice care is completely covered by Medicare.
We just got time for one question in the room.
Hi, Amberine, it's Allison.
Hi.
I always love hearing you talk. Question for you, I was taking pictures of some of your slides because the information on it seems so applicable to everything we all do, but from a caregiver perspective and impacted perspective, palliative seems final. So is there any thought of taking these concepts to the bigger picture, maybe the entire ALS experience rather the end?
Yes, absolutely. So that's why I think the hope is that having platforms like this and other platforms where we're starting to teach everyone how to do palliative care early on, then it doesn't need to be an isolated thing like, okay, now you're in palliative care. In fact, there's no such thing as you're in palliative care, because actually to that question, it's congruent, it's consistent when you're getting palliative care. It's alongside all the rest of the ALS care you're getting. So the hope is that it's no shift majorly and that you're starting to receive components as a care partner and as a family of palliative care from early diagnosis. And sometimes people need a little bit more training or they're not really sure how to do it or do it well, but the kind of also the reassurance that what you're doing, what the neurology teams and the non-palliative care specialty teams are doing, you're doing it, so just keep doing it is really a message that I think while we're always trying to do better, sometimes we forget that we're actually doing it as well as we can right now with the skills that we have.
Yeah. Thank you very much.
Thank you.
So next I'd like to welcome Kate Bursch and Lee Stevens to the stage. Fantastic. And they're going to present development of the community of practice for healthcare professionals.
Bonjour tout le monde, je m'appelle Kate Bush, je suis de la SLA Québec.
Bonjour tout le monde. Hi everybody, I'm Lee, also from ALS Quebec, and our presentation is on the development of our community of practice for healthcare professionals. So Sarah Feldman mentioned yesterday that she loved hearing about projects inspired by other presentations at the Alliance, and ours is no different. We wanted to send a little shout out to Jennifer Bedford. We were watching the APF virtually, Kate and I, in 2022, and when we heard her presentation on the development of a community of practice. And so we were texting actually during the presentation to be like, we need to find a way to do this in our community. And so we started discussing right away.
So some backstory. When I started at the ALS Society of Quebec in late 2010, we already had a table of partners. Shout out to Tony, to Mia, to Anne-Marie. They were involved in healthcare professionals who worked with ALS on a regular basis to talk about needs for families, but as well for healthcare professionals. So what we had done was we started creating education days. We created an aide memoir. I'm sorry, there's going to be a bit of franglais in this presentation. So a memory aid for healthcare professionals about what you may or may not have to deal with when you've got a patient with ALS. And then it was in 2012 that we came up with an idea. We called it the Forum des Échanges, an exchange forum for healthcare professionals to get together once every 2 months over lunch hour in order to discuss particular needs for families with ALS. And so our first forum was in November 2012. It was a teleconference, which meant that we all got together on a telephone and we shared quite anonymously. Since then, we've done more than 50 forums, and we have an average of about 50 people per forum. Sometimes we've had as many as 100 people on the line. So some of the subjects that we've discussed have been discussing difficult cases, end-of-life options, organ donation, sexuality, case management, nutrition, imposed occupational transition, physiotherapy, communication aids. We even had a pretty fabulous forum before marijuana was legalized in Canada on medical marijuana with ALS. In 2020, with the pandemic, we switched to Zoom, and community of practice then sort of seemed like an active extension of the exchange forums, and to create stronger links within the community and make it available every day rather than an hour every 6 to 10 weeks. Lee.
Thank you. All right, so in early 2023, we were trying to get organized, and I'll credit Kate, it was her idea to have a journal to track, our reflections, our actions, and to be able to really follow the process. We met with partner organizations that had expertise and experience in community of practice. And of course, we did some research on some platform options. It seemed that Microsoft Teams was an obvious choice because of its pervasive use in the healthcare system. And of course, then we created our team on Teams. We created a pinned post, which we'll show you later, a welcome post that explained the channels. We also developed tags for the healthcare professionals, so if a particular topic was of interest to OTs, we could tag them and try and nab their attention in particular, and language of use. We also created a couple of posts to kick off the discussion, namely the reflecting on the most recent exchange forum at the time. Yay!
So, we have pretty robust database of healthcare professionals in Quebec with over 1,100 healthcare professionals. So we invited all of them by email, including, of course, occupational therapists, physiotherapists, nurses, social workers, neurologists, nutritionists, SLPs, psychologists, psychoeducators, researchers, the list goes on. And we explained them how they could access the account, and they responded, and we had very few issues with access. We launched on September 29th, 2023, and then 3 workdays later, we had already 160 people joining us. Our first post from the community came in early October, and then by October 19th or 10th, we were over 180 healthcare professionals.
So I wanted to give you an example of our pinned, thank you, Kate, of our pinned post. So we wanted to include the most commonly needed healthcare resources for the healthcare professionals. So things like the guide for people living with ALS, our nutritional toolkit, the Canadian Best Practices Guidelines by Dr. Shoesmith et al. From 2020, registration forms to ALS Quebec, shameless plug for us, and our community support programs and many more items. so we thought so much about the content, and we were like, where is everybody? So we thought we needed to address engagement. In terms of brainstorming for content, we wanted to think about the kinds of things we would want to post in the coming months. So things like awareness days, like Occupational Therapy Month in Canada or Social Work Week in Quebec, show our appreciation for our fellow allied health professionals, information regarding new approval for therapies, opportunities to participate in research and share those opportunities with patients. It tended to be non-pharma type things like caregiving or more clinical allied health projects. Oh, no, I'm good. Advocacy and policy articles relevant to our population, of course, exchange forum invitations, and in the last year, we've had many, many posts about the APF and the symposium. We also created a calendar to plan our posts and track engagement from the community. And then we also, since the engagement was a little lower than we'd anticipated, we reached out to the healthcare professionals in order to get their feedback.
So we got feedback from about a dozen healthcare professionals, and their comments included things like technical difficulties, that it was cumbersome to have to switch between a normal teams that they do in their day-to-day with work, and then to switch to a community of practice. Because what we did was created a guest account instead of doing it through our work account. So some forgot about the community of practice as they are not triggered by notifications or emails. Their notifications were going into their junk mail. So some weren't seeing the content. Some needed a code to access the team. And some weren't sure that they'd been properly added. There was a shyness and a desire to not bother anyone by posting subject matter, but the subject matter that was posted was actually really great. And some people weren't using it because it was rare that they used Teams. They didn't have time. Some people weren't working enough with ALS patients to find that it was useful. And maybe because some people asked if we could do a Facebook group instead, but that isn't possible with healthcare workers to be able to have Facebook access, whatever. Some changed jobs, some preferred emails, etc. So the platform challengers, we were thinking, like, how do we resolve this? Microsoft is aware that they need to integrate guest accounts to a main platform, but they haven't done this yet. So we're waiting on this adaptation, and we kind of, harass Microsoft to get them to be aware that we think this is an issue and they should do something about it. So as of April 2024, we started to see much more engagement, people liking and responding to our posts, but it still is not as much as we had hoped for, but it appears that people are starting to remember it as a possible resource. So where are we now? We were wondering whether our own expectations matched those of the healthcare professionals. And so we did another survey just recently to see what their thoughts were in October. The results were that expectations of a community of practice was to share knowledge and help each other, a place to ask questions, and to be informed of new developments. Their lived experience was that the feedback is that the posts are interesting and helpful, but those who did not engage, they do continually cite lack of time and inconvenience of toggling between the team platforms. But does the community of practice respond to their needs? It was an overwhelming yes, but we just really do need to deal with that toggling issue.
So I think I saw Liziane here at some point. I'm not sure if she's, nope. No hand raising? Okay. So we were in touch with speech language pathologist, she's a PhD, postdoc, thank you. And she put us in touch with another person with community of practice expertise. Her name is Dr. Ingrid Verducht, and she's running a community of practice for speech language pathologists. And so we were able to learn quite a bit from her. We spoke with her in October as well. And so here's some learnings that we got from that conversation. So mapping of our healthcare professionals. So she asked questions like, what unites the group other than ALS? Do we need subgroups? Do we need to specialize? What is the core message and who does that interest? And Kate's mentioned it a couple of times, and I think we have an acceptance piece here where to integrate, in the sense that not all healthcare workers working with ALS do it full time the way that we do. You might have a case here and there, or be more or less engaged with the community, and there's a big variety. And so we have to manage our expectations in terms of, it may not be normal for everyone to be as engaged as we would like to be on a daily basis. In terms of the team's challenges, Professor Verduck's experience was similar to ours. In fact, every year they review the platform options for their community of practice. They end up coming back to the teams as the lesser of evils for now, and are also anxiously awaiting Microsoft's update. But they use email backup while they're waiting for the improvements to the platform, which was reassuring to us as well, because that's something that we took on as well. And coming back to the table de partenaires that Kate spoke about at the beginning, there's a need to establish a core group of people. So people that could help identify people to launch forum discussions, people that would commit to posting regularly, and that will help with the engagement as well. And so some of our latest reflections and plans for 2025, we would like to boost the frequency of the Exchange Forum. For a variety of reasons, the frequency sort of fell off the last couple of years, and it's something we really need to get going again. And the survey actually reinforced that feeling as well, that we need to meet more often. The other thing is that we're increasingly developing relationships with researchers and students, and so inviting them to the community of practice and to present to the healthcare professionals can help solidify those links. And a comment from one healthcare professional expressed a desire to have more case studies to analyze needs and solutions found to inspire others as well. So we're coming back to that collaborative theme that we keep talking about. So we'll continue to reflect on our process, and maybe we'll be able to give you an update next year.
Please feel free to contact us. Merci beaucoup.
Fantastic. Thank you so much. It's so exciting that you can find and meet people and kind of cross-pollinate and just share ideas. It's really inspirational. So thank you. And interesting enough, Jen is coming up next, and you'll be able to share more. Are there any questions in the room?
So I apologize, Kate. So I don't know if I've ever shared this, but there was a nurse from Switzerland that posted on your post, and then we hosted him for a week because he was setting up a clinic in Switzerland. So I don't think that ever, and that was all through the forum. So FYI, guys.
Thank you for that, Tony. It's great. It's great to hear that. Very appreciated. Thank you very much.
Are there any more questions? Are there any questions online? No? Lovely. Well, we'd like to thank you once again for your presentation. Thank you.
Thank you very much.
So now we'd like to welcome Jennifer Bedford and Jan Clark, and they're going to talk about the evolving MND professional community of practice.
So thank you very much for the invite. My name is Jan Clark, and I'm a consultant nurse in MND at the National Hospital for Neurology in London in the UK. I'm also chair of the expert core of the community of practice. And my assistant,
Not so glamorous, and I've got my name wrong on the slide, so
it's Jen Bedford from the MND Association. Let's see if I can work the technology. Green button. Here we go. So we set up our community of practice 3 years ago, and it was presented at the APF in San Diego 2 years ago about where we got to at that point. So we just want to bring you up to date to where we are now. So this is 3 years on. So we've continued to build our community. It's growing fast, which is really great and exciting. I just need my glasses to read my notes. So, as our community continues to grow, we realize that we need to engage with them and to work out what it is what they need. They're really engaging, motivated group of professionals, and our basis behind this is to encourage and support and share good practice and emerging research in MND so that we drive up the care that's delivered to people with MND or affected by MND. Behind our forum, we have an expert core. So you talked about having a group of professionals. We have an expert core. It's about 30 members. It's multidisciplinary, and it covers every profession that we can think of, although, Melinda, we're very short of a social worker. So if you could. But so we've got these 30 members, and they're the people that work in the very top of their profession in MND across the UK, and they're there to sense check the information that we give out and to talk about topics that are related to their own professional disciplines. So it's really exciting, and actually we're really excited because we've got Rhiannon this year. She's the only orthotist in the UK who now uses 3D printing to make orthotics. So as Philippa said, one size doesn't fit all, and now we've got somebody on our expert core who can share that information across the UK to our community of practice. So we're very encouraged by that. Our membership now stands at 1,600, which we think is quite awesome. And spread across the UK is quite wide. We've got good spread north and south. We've got it in our devolved nations of Scotland and Wales and Northern Ireland. And as you can see from the bottom slide, we've got a good spread of professions that attend our forum as well. So what do our members really appreciate? I think it's those. We do things in slightly differently to the people that presented before, that we run something called information and knowledge exchanges virtually. We run them 3 times a year online, and they're well advertised beforehand, and we have particular topics for them. We also have a face-to-face network meeting once a year, and we had our last one in October. We have an online forum platform where people, wherever they work, because what we're very aware of, our expert core is very embedded in working with people with MND, but lots of our community of practice colleagues may have it as part of their caseload along with other patients, so they don't have to hand perhaps the knowledge you do if you work just in MND. So having an online forum where you can ask a question about what's the best next support for this, or I've got a patient with this complexity, I really don't know where to go, and get a response, because it's monitored by the expert core, out to you wherever you are, whether that's in rural Scotland or sort of the sunny coast of Cornwall, is really useful. Our IKEs, as we call them, our information and knowledge exchanges, so are really brilliant. We have up to 400 people signing up to each session that we have, which is amazing. And they run in real time. They're 2.5 hours long. They run over a lunchtime period, so from 11 till 1:30 in the UK. And you can dial in for all of it or some of it, whatever works for you, wherever you are. So this year in particular, we've done a saliva management course. We've looked at thick and thin saliva and the complexities and the trouble with medications and the availability of Botox. And we've really gone through that. We've also looked at managing high tone. And then the last one we had was coping with complexity. And then what happens after the experts delivered this session online is that then we have the ability through Zoom to go into breakout rooms. So all the community of practice can ask direct to the presenters questions. The expert core supports these meetings, so there's a facilitator in each breakout group online, so that you can really get into it and discuss problems in your particular area. And what we want to do with this network is put people in touch with each other, because what works in London maybe doesn't work in sort of the Outer Hebrides, and so you can talk with people and learn how to do that. And then our annual networking event has gone from strength to strength, that we've outgrown the premises from where we had it last. The last one we had in October, we had over 200 attendees and created a waiting list for people to take places on that. It was an amazing day. That day is not about PowerPoint presentations. We'll have a keynote speaker, but then we have things around the room, little groups around the room, and we had how many rooms do we have? 10 rooms or something, where we had all our expert core delivering little groups. So Rachel and I did sex and intimacy. There was groups on REMAP, so Philippa's use with REMAP, the service about REMAP. REMAP was there listening to people with professionals in MND about how they may make things like movable collars or the magnetic hat, which is brilliant. I think that would work well in a baseball hat as well. So it was a really great event. But don't take my word for it. We have a very short video now, and apparently if I press this twice, this should work, about interviews that were taken on the day.
If there's any sound. There's no sound.
Hang on, I think it's coming again. Oh, okay.
Talk amongst yourselves.
We should have brought a packet of raisins up here, shouldn't we?
Everyone smile. Everyone smile.
Networking with others has been really helpful and beneficial, and particularly those that are looking at supporting carers within the MND community.
Well, I definitely recommend it because I was here last year, so I think that probably speaks for itself. And the more MNDA events you come to, you build up your network of peer support. So when you are back in your clinical practice, you've got people you can draw on for if you've got situations that you need support with.
It's just great to see some people I've met at similar events over the last few years and catch back up with them and just re-establish links, because it's always handy to know who to email to ask for different tips and advice. For example, we bumped into a psychologist today and we're trying to improve our psychology service, so we're going to be emailing one another after this event, having re-established that connection.
Lovely, thanks for that. I'm glad we got there in the end. That was great. And I'm sure you'll want your lunch, so I'll be brief. But the next stage for us now is maturation, which if you look at the Etienne Wenger model of a community of practice, that's what we're moving into. So what we know, our members really do feel significant support from being part of the community. We've got great depth and breadth of experience that we now have within the community that we can use and make really great strong bonds between each other. People talk about it being a national MDT, which is absolutely fantastic. And we have a great level of trust going forwards. So that's really fantastic. So we're quite excited. And what next? So we've looked at a structured approach to the development of the community of practice. So the following things, and I'm going to talk about them afterwards. So it's the Demands Project, which is a suite of workforce surveys, a national pathway and resource development, our annual networking event, and international connections. So the Demands Project I wanted to talk about is that we've done a pilot with speech and language therapists. And what this is to do is to find out more about the people that are actually in our community and learn about them and find out what they really want, are we meeting their needs, but also to understand what's going on for them in their professions. So we've been working with a fantastic consultant to help us on this one, design the survey, and yeah, we put it out there, so we've got the stuff back, which I'll talk about in a sec. But the exciting thing I wanted to say is that we want also to do this with the other 4 professions you can see on the slide there. And that's live at the moment, so we're gathering in all the information. So just to talk quickly about the demand study, we did quantitative and qualitative studies. And what came out of that, which is, it's a whole other presentation really, what's coming out of it. But we're learning a lot about the workforce, and I think it's been referenced before here as well. So we're seeing a part-time workforce in this area, people working 72%, 10 years plus, varying settings, they're inpatients, they're in the community, and the postgraduate levels are high at 43%. We also know the hours they're working with people living with MND, so we have an idea of what people were talking about here was the kind of how much do you work with people with MND within perhaps a mixed caseload. And people are saying the mode is around 5 hours per month working with people living with MND. We know about the process of how people are working. So how are people living with MND experiencing the services through speech and language therapists? 70% of MND patients, we're really pleased to note, were able to get a prioritised referral through to speech and language therapy, which is really encouraging. We're also hearing from speech and language therapists that they're able to make home visits, which reflects people living with MND's preference, and also references the holistic approach that we're seeing through the community of practice, and also echoing what people are saying here, which is this is an MDT approach. No one person can look after somebody living with MND. And really what this is saying is that if a speech and language therapist can go in, they can maybe take a colleague with them as well. So they're not bombarding people with so many visits. They can do one really good visit at once. In terms of practice, people, over half of the speech and language therapists said they could set their own review times. We have encouraging percentages around voice banking, with 78% of people saying that they can refer people within weeks, 2% within days, but always proactive and according to patient need, which is obviously what we're looking for here. We also know about the CPD, and we know that the confidence predictably goes up with experience. In terms of qualitative data, it's obviously much more difficult to get those onto the slides because I could go on forever with some brilliant stats and some quotes from people about that. But we're understanding more about how people go about their roles, what their feelings are about their roles. One interesting quote that I did want to just reference was, they say about working with people with MND that we don't have the time, but we make the time, which I think is really how that's operating a lot, where people we know are under stress with time and paucity of time, paucity of resources sometimes. We know about the training that they want, the knowledge that they want. They want knowledge about MND specifically. They want SLT-specific content as well, and they want to talk about difficult conversations, which I prefer to call emotional conversations. The emotional load of working with people living with MND was interesting. They talk about positive and negative of that. The positivity they get from being actually connected with the people that they're working with. And obviously then there is that emotional load on them as practitioners. So that's what we're looking at. So what we're trying to do from this information is then to start to tailor what we're doing with this group. So there are pilot groups to start off with. One thing that came out was the importance of speech and language therapy assistance, which is important. And I mention that particularly because they can pick up some of the non-complex stuff, freeing up time for the specialists to be able to meet the more complex needs of the people they're working with. And the reason I mention that particularly is because we're doing this with OTs, physios, etc. And we may find that echoes across, because what we'll be able to do is use the different professions to interlink and see where the similarities are, and then make a really good response to our network. The other thing we're doing are looking at pathways and aids to practice, and we're doing this through our care centres and networks, who are represented by care centre coordinators. We have 23 care centres and networks across the UK, and they're a really rich group of people that we can work with, and they form a kind of a discrete group of people, if you like, within the community of practice. We identified this at a meeting that we had, and these are the 3 projects that we're working on between 2024 and 2025. Saliva management, we want to develop a national pathway to be able to support people to build their local pathways, if you like. So a kind of an overarching one that people can then identify what they can use in their own areas. We're also looking at a risk assessment for discharge with a nasogastral tube. It's unusual, but what we're trying to do is produce something so that when people discharge someone with a nasogastral tube, they've kind of got that document there. Because it's so rare, if we can create this one, then that people can pick that off of the shelf. And finally, eating and drinking with a knowledge risk. This is an interesting one. It comes up all the time at when we're talking with our community. And it's the ethics around feeding someone with that knowledge risk. Not only because obviously there could be a bad incident that happens with that, but it's someone's right to eat what they want to eat. But there's the ethical stance in terms of what happens literally if there is going to be a choking incident, but also how that potentially could make a practitioner feel. So we're exploring that area. That's much more nebulous, I would say, in as much as we're trying to explore what people need in that space. So 2025 annual networking event, it's going to be in October again, probably Birmingham again, because we've got a bit of an affinity with that. We're looking at it being much bigger. We've totally outgrown our location now. So we're going to be renting probably 3 more spaces there to be able to meet the needs of our community. We're going to add a poster element, and we're going to have more demonstrations taking place there. There's so much I could talk about. Honestly, I could go on forever. So, developing international connections. This is a spoiler alert for the Pass It On project, which is coming on later on. You'll see us later. But also here, I did want to mention that if any of you are interested in joining the community of practice, we can't give you the bursaries that we give our other people. We can't give you our continuing professional fund money, because obviously we're a charity. But if you ever want to join into our IKES or join our community, please do. You'll be more than welcome. And do go on our website. Oh yeah, I didn't mention, all of the videos are recorded, so if you became a member of the community of practice, you'd be able to see back ones, and there's also a whole education program on there as well, so we have a whole series of webinars too. So yeah, please, come and find me. Thank you.
Jen and Jan, thank you so much. It's so exciting to see how the community of practice has grown year on year, and you're a little bit ahead of Kate and Lee, and just seeing how that would kind of pan out in the future. Are there any questions in the room? Somebody's having a stretch? No, not a question. Kate and Lee mentioned that they had initial teething problems with some of the tech and finding the right platform to develop their community of practice. Is that something you had thoughts about, or can offer any support, help?
Yeah, we didn't go for a particular platform. So what we do is we use Zoom for the meetings. We find that Zoom works with the NHS. It's a neutral platform, so anyone can use it. So people can dial in from anywhere to use that one. Yeah, Teams is much more restrictive. I'm trying to set up an external Teams channel, and I've had all sorts of issues internally on that one, but we find that Zoom works really well. And I think we also have that forum element through Facebook is currently what we use at the moment, so that's where people are exchanging their ideas and interest in there.
Great, thank you. Any questions? No, just saying thank you so much. It was brilliant. So just before you go to lunch, there's been a request from a PM&R doctor. Is there somebody in the room who, yay, jumping here, who would like to meet fellow, we are matchmaking today. So if you are a PM&R, come and find her. Thank you. The raffle prizes have been drawn, and they're on the feed loop. They're also going to be on the board. The numbers are on the board by the raffle prizes themselves. So do please go and have a look. We're going to break now for lunch, and if you can come back at 1:55, that would be lovely. Thank you.